Please start.
Thank you, sir. Very good evening to all of you. Today, Research Society of Anesthesiologists, in coordination with the Research Society Anesthesiologist Patna branch, is conducting the webinar with the theme Problem-Based Learning Sessions in Pediatric Anesthesia. It's my proud privilege to welcome our President, RSA, Dr. Naveen Malhotra, sir, and Secretary, Research Society of Anesthesiologists, Dr. Vishal Singla, sir, both as webinar partners. May I now introduce the chairpersons for today's webinar. We have Dr. Sanjay Chaube, sir, from Lucknow, and Dr. Parul Jindal, ma'am, from Dehradun. Welcome, sir. Welcome, ma'am.
Thank you.
May I now request our Honorable President, Dr. Naveen
Thank you, Vaibhav,
sir, to share his words of blessings with us.
Thank you, Dr. Vishal Vaibhav, and heartiest congratulations to Team Research Society of Anesthesiology, Patna City branch, under the able leadership of Dr. Nishan Sahe, the National Governing Council member and editor of the RCP Times, the official newsletter of Research Society of Anesthesiology. I am very happy that he is actively involved in numerous affairs of Research Society of Anesthesiology, and he is ably joined and supported by two very dear, very intelligent pediatric anesthesiologists, Dr. Sanjay Chaube, past National Governing Council member, a professor and head of Era Medical College, Lucknow, a very dear friend and a very fine pediatric anesthesiologist. And I can say that his students love him. And he's a very good teacher. He's a very good teacher also.
Thanks, Naveen. Noble words.
And Dr. Parul Jindal, she is a professor at HIMS Jolly Grant, Dehradun, an excellent lady who has been the past president of Uttarakhand ISA State Chapter and National Governing Council member of Research Society of Anesthesiology. And she is also a very fine pediatric anesthesiologist, an all-rounder in profession. You name it and you have it, whether it is academics, clinics, research, and co-curricular activities, wellness programs. She participates actively and enthusiastically in all. And personally, I can say that she's a very good mother also, in addition to being a very good wife. And welcome, Parul.
Thank you so much, sir. Thank you.
And no webinar is complete without the speakers. So I personally thank from the bottom of my heart Dr. Abhishek Chatterjee, Dr. Shagufta Nas, Nishan Sai himself, and Dr. Swati Singh. Best wishes to all, and I'm very sure that you will be doing justice to today's webinar, and delegates will be enriched from the deliberations. I request all to please stick by time so that we can have a crisp session and we will wind by 7:25 p.m. or so. I'll just like to make one more announcement that this Sunday evening, we are starting with the first session of Research Society of Anesthesiology Youth Conclave. The youngest minds will be sharing their ideas, and it will be every week in the evening, 6 to 8 p.m. online. And coincidentally, two of the persons present here are the judges in the first session. Dr. Nishan Sai and Dr. Parul Jindal will be judging these students along with Dr. Swati of the Joint Secretary of Research Society of Anesthesiology. Why they will be judging and they will not be presenting? Because they are numerically aged more than 40 years. So yes, they are young at heart. We are just sweet 16, but coincidentally their Aadhaar card shows that they are 40 years plus. So they will be in the role of judging and the youngsters will be presenting. So best wishes to all. Thank you very much.
Thank you so much, sir. Now, may I request our Honorable Secretary, Research Society of Anesthesiologists, Dr. Vishal Singla, sir, to kindly say a few words on today's webinar.
Good evening, everyone, and greetings from Research Society of Anesthesiology. Respected the President, Dr. Naveen Malhotra, sir, and the organizing chairperson of today's program, Dr. Nishan Sahai, The success to any webinar is by active contribution of the speakers as well as the chairpersons and of course the faculty, as the sir said, who will be deliberating today. I'm sure today's webinar will be quite enriching for the practicing anesthesiologists as well as the students. I extend my best wishes to the faculty and the organizing team, Research Society of Anesthesiology, Patna, for this wonderfully crafted and very clinically oriented webinar on pediatric anesthesia. All the best and thank you very much. Long live Research Society of Anesthesiology. Over to you, Dr. Vishal, please.
Thank you, sir. Thank you so much. We now proceed for the today's session. And for this, may I now request our chairpersons, Chairperson Dr. Sanjeev sir, to kindly invite our first speaker, Dr. Abhishek Chatterjee sir from Jamshedpur.
Dr. Sanjay, just a minute.
Yes.
Dr. Nishant, I am making you host, so you take over from here. Okay, you can make other posts.
Right, sir. Thank you.
Sanjay, please can continue.
Yeah, I would request Dr. Parul Jindal to do the honors of giving a brief introduction of the speakers and welcoming them. Followed later on, I would also be sort of greeting them. Huh? So, Dr. Parul, can I request you, please?
Yes, sir. Thank you so much, sir. It's my honor and privilege to invite our first speaker for today, Dr. Bhattacharya, who is a consultant at Tata Memorial Hospital, Jamshedpur. And he'll be discussing on a very important topic, delayed recovery in after anesthesia in children, which is also called as delayed emergence. And this can be caused by a number of factors like anesthetic agents, the medications, the metabolic disorders, underlying medical conditions. So I'll ask Dr. Abhishek Chatterjee to please share his screen. And we'll have the discussion after all the four speakers have taken their topics. And please post your questions, your queries in the chat box, which we'll take later on. Thank you so much. Over to you, Dr. Abhishek.
Yes, we are able to see Abhishek. Yes. Okay.
So we can start.
Right, इसको minimize. ये minimize करती है. So good evening, everyone. I hope I am audible and my slides are visible.
Yes,
Yes,
sir.
sir. Please go ahead.
Thank you. So thank you, Dr. Parul. Good evening, everyone. At the outset, I would like to thank the Patna branch of Research Society of Anesthesiology, as well as President of RSA and Secretary of RSA for giving me this opportunity. Today, I will be speaking on delayed recovery in pediatric patients, causes and management. Recovery from anesthesia may be defined as a state of consciousness of an individual when he is awake or easily arousable and aware of his surroundings and identity. Awakening results from elimination of anesthetic agents from the brain. Patients usually respond to verbal stimuli when the alveolar anesthetic concentration is decreased to about 30% of MAC value, which is also known as MAC awake. Literature search have shown that the incidence is not very rare, and the incidence of delayed recovery or delayed emergence in pediatric patients ranges from 1.38% to around 10%. The phases of recovery of anesthesia has been classified into immediate recovery, intermediate recovery, and long-term recovery. Now, coming to mechanism of recovery. On the molecular level, the effect of general anesthetics is achieved through their action on different types of receptors, including type A GABA receptors, NMDA receptors, as well as alpha-2 receptors. Functionally, the drug receptor interactions leads to several changes in cortical and subcortical signals, inducing alterations in the connectivity across brain regions. Complex mechanisms underlie alterations of cortico-cortical and cortical subcortical functional connectivity. During the recovery phase or emergence from anesthesia phase, mechanisms responsible for loss of consciousness and anesthesia maintenance are gradually reversed. Active processes include several ascending arousal brain pathways where the thalamus plays a key role. Orexin, which is also known as hypocretin, is an endogenous wakefulness promoting substance. Hypothalamic orexinergic neurons are involved in both the sleep to wake transition and maintenance of wakefulness. This is a table showing the different causes of delayed recovery, which can be classified into patient-related factors, drug factors, surgical and anesthetic procedure-related factors, and metabolic factors. Now, coming to one by one, the first one is patient-related factors. Because of larger body surface area, the heat loss is greater in pediatric patients, resulting in hypothermia, slowing the drug metabolism, and delayed return of consciousness. The incidence in male child is 1.4 times than female child. And patients or pediatric patients with genetic defect of metabolic pathway of anesthetic agents, abnormal or absent plasma cholinesterase enzyme, or patients with Down syndrome and cerebral palsy usually have delayed recovery. Next is the pharmacological factors. A heavy pre-medication or the relative overdose of general anesthetic agents may be the cause of delayed awakening. A large number of pharmacological interactions with neuromuscular blocking agents like aminoglycosides, diuretics, calcium channel anesthetics, etc., will prolong neuromuscular block. The selection of anesthetic technique and anesthetic drugs determines the duration of unconsciousness. Time to emergence increases with increasing duration of anesthesia. Recovery may be delayed if soluble volatile agents are continued until the end of surgery, or long-acting drugs are given towards the end of the procedure. The sensitivity of the brainstem chemoreceptors to carbon dioxide is reduced by opioids, with consequent dose-dependent respiratory depression and hypercapnia. This may affect clearance of volatile agents and carbon dioxide. Both of them can cause delayed recovery. The speed of emergence is directly related to alveolar ventilation and inversely related to blood gas solubility. Hypoventilation lengthens the time taken to exhale the anesthetic agent and delays recovery. Prolonged duration of anesthesia causes increased emergence time due to tissue uptake depending upon the concentration used and drug solubility. Another important factor is that if the vaporizers are not calibrated correctly, higher than expected dose may be delivered, especially if end-tidal drug concentrations are not measured. Coming to the metabolic factors, the important factors are hypo or hyperglycemia, dyselectrolytemia, and hypothermia. Hypoglycemia can occur in children with prolonged fasting. It may also occur in underlying septicemia. As the brain is totally dependent on glucose for energy, hypoglycemia may manifest as sweating, seizures, or coma in the intraoperative period. Hyperglycemia occurs in pediatric patients as the result of injudicious glucose administration. Hyperglycemia causes an osmotic diuresis and intracellular dehydration. The effects of dehydration ranges from development of acidosis to drowsiness or delay in recovery, or it may lead into coma. Dyselectrolytemia includes hyponatremia and hypokalemia. The acid base and electrolyte changes observed in the perioperative period could be secondary to the underlying illness or the surgical procedure itself. Hyponatremia can result in irritability, drowsiness, confusion, and if it is of severe grade, it may lead to coma. Hypokalemia intensifies the effects of non-depolarizing muscle relaxants. respiratory alkalosis with hypocarbia results in reduced intracellular proton concentration and it draws potassium into the cells. It has been seen that there is a reduction of about 0.5 milliequivalent per liter of potassium per 10 millimeter Hg reduction in PaCO2. Also occur with perioperative use of diuretics, calcium agonists, beta adrenergic agonists, sodium bicarbonate, and glucose. Mild preoperative hypokalemia without any clinical features could rapidly deteriorate after iatrogenic hyperventilation or surgical stimulation and delays recovery. Hypothermia is usually observed in neonates and infants. A core temperature less than 33 degrees Celsius has marked anesthetic effects itself, and it also reduces MAC value of inhalational agents. It antagonizes muscle relaxant reversal and limits drug metabolism. Central anticholinergic syndrome occurs not only with anticholinergic drugs like atropine, scopolamine, or hyoscine, but it also occurs with use of benzodiazepine and volatile agents, and it manifests as delayed awakening from anesthesia. It is thought to be due to a decrease in inhibitory anticholinergic activity in the brain, and symptoms include CNS depression with stupor or coma. Overdose of atropine or glycopyrrolate is reported to cause central anticholinergic syndrome, and the incidence varies from 1% to around 11% after general anesthesia. Now, to deal with individual conditions, hypoglycemia has been defined as a blood glucose level of less than 50 milligram per deciliter in patients with less than 2 days of life, and in patients of more than 2 days of life, the cutoff limit is 60 milligram per deciliter. It can manifest in the intraoperative period either because of autonomic symptoms or because of neuroglycopenic symptoms. Autonomic symptoms during surgery includes tachycardia, sweating, and hypothermia, whereas neuroglycopenic symptoms include delayed recovery and motor or sensory disturbances. And on the right-hand side, it is the management algorithm for hypoglycemia. If blood glucose is less than 2.6 millimoles per liter or less than 50 milligram per deciliter, then we should not delay treatment. And since during surgery, we have IV access, we should administer IV bolus dextrose 2 ml per kg. 10% dextrose is recommended. And our target is to raise the blood glucose level up to 60 milligram per deciliter. If blood sugar level increase to 60 milligram per deciliter, then only maintenance fluid will be adequate. Or else, if it is less than 60 milligram per deciliter, again we have to administer 10% dextrose at a dose of 2 ml per kg. Hyponatremia, especially severe hyponatremia, has been defined as a sodium level of less than 120 millimole per deciliter. Acute hyponatremia can lead to cerebral edema and it can cause delayed recovery in pediatric patients. We have to remember that if there is acute severe hyponatremia, we must monitor blood glucose level. If hyperglycemia is present in addition to hyponatremia, we must manage the patient as per diabetic ketoacidosis management guideline. If it is severe hyponatremia, we have to administer 3% sodium chloride at a dose of 3 ml per kg over 20 minutes, and we have to recheck sodium level. If sodium level becomes more than 125 millimole per liter or there is termination of seizure, we can continue with maintenance fluid only. Else, we have to repeat 3% sodium chloride. If the sodium level is more than 120, but it is less than 130, then we have to assess the hydration status of the pediatric patient. If the child is dehydrated and sodium is less than 130, then we have to administer IV isotonic fluid. If child is dehydrated, but sodium is more than 130, then we can manage with oral rehydration solution only. Hypothermia is also graded into 3 categories: mild, moderate, and severe. If body temperature is between 32.2 to 35 degree, it is mild. 28 to 32.2 degrees Celsius, it is moderate. And if it is less than 28 degree, it is severe. The manifestation during the intraoperative period varies as per the degree of hypothermia. On the right-hand side is the management guideline of hypothermia. If it is of severe nature, there is very high possibility that the child may go into cardiac arrest, and then we have to manage accordingly. And in case of mild to moderate hypothermia, we have to go for passive external rewarming with the help of bare agar system, or we can go for minimally invasive active core rewarming like administration of warm IV fluids. Narcotic overdose is also a known cause of delayed recovery in pediatric patients. The manifestation may include delayed recovery, respiratory depression with decrease in rate as well as depth, development of meiosis, bradycardia, hypotonia, decreased bowel sounds. Patient may develop cyanosis if there is severe hypoxia, and it may be associated with hypothermia also. Naloxone is the antidote, as all of us know, and it should be administered at a dose of 0.1 mg per kg IV initially, and it can be repeated. Respiratory support, fluid resuscitation, and gastrointestinal decontamination are the other management plan for such type of patients. Now, if a patient develops delayed recovery after the surgery is over, then how should we proceed? So this is a guideline which can help us. A patient who is undergoing surgery, we can start from the 3rd step, that is assessment of the disability. We should check for pupillary response, we should measure core temperature, and we should perform an ABG analysis to check for oxygen status, carbon dioxide status, blood sugar, and electrolyte status. And then we have to manage the patient accordingly. We must review our anesthetic chart to exclude administration of relative overdosage of anesthetic agents. And if the delayed recovery status continue for more than 1 hour, then we should proceed for CT scan of patient's brain to rule out other neurological causes of delayed recovery. To summarize, this is an algorithm which all of us can follow in case of delayed emergence from anesthesia. Airways should be protected. Usually in pediatric patients who are undergoing major surgeries under general anesthesia, airway is protected with endotracheal tube. Then we should review our history. We have to assess drug, their timing, and drug interaction. And this is the basic algorithm which all of us should follow in case of delayed recovery. Thank you.
Yes, Abhishek, you will stop sharing now. Vishal, can we start? Can we go ahead? You are unmuted. Unmute yourself. Can you unmute yourself, please?
Yeah. So before we begin, go any further, it's my honor to welcome Dr. Maya Tandon ma'am, Padam Shri Maya Tandon ma'am, who's joined us today. Nishant, would you like to please introduce her?
Yes, it is an absolute honor actually that ma'am has been able to spare her time for us. She's such a senior person, and we have we have been fortunate enough to see so much of honor being given to her. And ma'am, it will be an honor if you could just speak a few words on the occasion. She has been a champion for roadside safety for many years now.
So nice. I'm really happy that I've really been back into my fraternity. I've been admiring the anesthesiologists not only because the time which I've just introduced myself as former HOD, which you will be able to see in the text that I've written, but the very fact that those times when we were there in at the SS Medical College, although we were, putting our foot down for many, many things, but the way today anesthesiologists have grown, I'm really, really very happy and give my blessings to all of you. Now, saying that as an HOD anesthesia and went to Commonwealth Fellowship in Pediatric Anesthesia in 74, 75, and coming back, and before my retirement, I thought I'll have to do something different. So I started giving training on how to save the life of a road accident victim, which carry a heavy toll of human life in the country. And just starting soon after my superannuation in 1995, 30 years down the line, in 22nd April 2024, I was conferred with the Padma Shri Award for social work. Now, social work, because I am now a social person, people know me as a lifesaver. Now, so on this platform, I would like to say that please see your dreams to come true today. Like today, the youth who has spoken, the first speaker and all the others who have joined should take motivation from me to say that they should not only think of getting a Padma Shri, they should think in getting much higher than what you all are today, in fact. And your acumen today is so much that there is nothing which I can think is comparing to either a physician or a surgeon or anybody else in the medical field. I can bless you and keep on listening to things in not only RCPK and so on and in ISA, and this is what I have to say. Thank you very much for inviting and asking me to speak for a few minutes. Thanks a lot.
Thank you so much, Dr. Maya. And indeed, we are blessed to have you with us. And I, on behalf of this August gathering, would like to extend all our heartfelt pranam to you. And it's such an honor to have you with us in this session. And throughout the session, you would see the young faculty making their presentation and making their mark on the field of anesthesiology. So, welcome once again, and thanks a lot again for agreeing to be with us. In the same breath, I would also like to express my gratitude to Dr. Naveen Malhotra, President, RSACP, Secretary, Dr. Vishal Singla, and of course, to the faculty out here. Of course, the first speaker I would like to go to Dr. Abhishek. So that's a wonderful presentation. And Abhishek, just to remind you, I am from the same institute where you are working right now, way back from 1985 onwards. So we have had in the training in the same OT where you have had, and likewise after me, Dr. Nishant Sahay, he is privileged to have the training in a medical college as well. So that's a bit of brief outside the discussion pad. So next, I would like to just greet Dr. Shagufta. Now she is going to make a presentation on brachiocephalic central venous cannulation, a novel approach in children. Just to remind you, we would be having a discussion after all the sessions are done with. That's just to maintain the timings of this particular session. So of course, welcome Dr. Shagupta. Please go ahead with your presentation.
Thank you, Dr. Sanjay. I would like to thank the Patna Research Society of Anesthesiology for giving me opportunity to speak on this topic. And I would also like to thank our President and Secretary of RSACP. Today, I am going to speak on the topic brachiocephalic central venous cannulation, a novel approach in children. Central venous catheter insertion in neonate and small infant is challenging and high-risk procedure due to the smaller size of vessel and proximity to other structures. Cannulation using ultrasound increases the success rate and reduces procedure-related complications. Ultrasound-guided supraclavicular cannulation of brachiocephalic vein is a new approach that may be advantageous in cases of difficult central venous catheterization. Indications, as we all know, for central venous cannulation are difficult peripheral venous access, need for prolonged vascular access, need to monitor central venous pressure, example, large fluid shift or blood loss or cardiovascular surgery, need for vasoactive infusion and total parenteral nutrition. Various approaches have traditionally been used for central venous cannulation. The large vein of neck and thorax and that of the lower limb are used, like internal jugular vein, subclavian vein, external jugular vein in some instances, femoral vein, and brachiocephalic vein. IJV cannulation is the most common choice because IJV is large and runs superficial to the carotid artery. Primary advantage is the direct route to the right atrium and high rate of optimal catheter positioning. But primary disadvantage of IJV cannulation is difficult cannulation in small infants with large head and short neck. Difficult to obtain the shallow angle of approach to access the vessel. In 10 to 15%, there is incidence of carotid artery puncture, and awake infants may not be comfortable with IJV. Tip migration may be significant while turning the head or flexion or extension of the neck. The lower success rate of IJV may be due to technical difficulty in small kids, like small size vessel, scanty room for maneuvering, and vein collapse with breathing. Also, the vein collapses when the transducer is kept on the neck to scan IJV. Subclavian vein cannulation. Subclavian vein is positioned immediately behind the medial third of clavicle. Advantage of this route is it is relatively constant in position in all ages. There's less tip migration as in case of IJV, and the patient is comfortable even if he is awake. But disadvantage of subclavian venous cannulation is incidence of pneumothorax because of close proximity to pleura, occasional inability to dilate the space between the clavicle and first rib. 5 to 20% of patients have subclavian catheter which enter contralateral brachiocephalic vein or ipsilateral internal jugular vein, leading to malposition of the catheter. Ultrasound is ineffective during the traditional subclavicular approach of subclavian vein cannulation because of the clavicle, which acts as a barrier for ultrasound, and it prevents the needle control during the procedure. Femoral vein has long been used for central venous catheterization in children. Studies have shown that there is no greater risk of infection or complication with this route, and it is central venous monitoring. Pressure monitoring can also be done with this, but it has disadvantage that it presents anatomical variation with regard to its position relative to femoral artery. In very small newborn and infant, it is very small, approximately about the size of 50% of internal jugular vein. Thus, it carries a high risk of arterial puncture and difficulty in introducing the guide wire and catheter. So coming to brachiocephalic venous cannulation, as we can see in the picture, this is left and this is right and this is left brachiocephalic vein. This is the largest size vein for percutaneous cannulation in children below 6 years of age. It is simple to visualize with ultrasound in small children due to its superficial location, and it allows in-plane longitudinal approach with improved control of the needle. Unlike internal jugular vein, the size of brachiocephalic vein does not vary with breathing or with external compression or movement of adjacent tissues. And it has been proven to be useful in patients with hemorrhagic diastasis since the supraclavicular puncture area may be compressed. Other advantage of brachiocephalic cannulation is especially useful in patients with IJV vessel human, where it is very small, as in case of volume deficient patient. In patient where history of multiple cannulation is there, and the IJV or other central vein are not being cannulated, and in whom subclavian puncture is contraindicated. Now, coming to the technique of insertion of central line through brachiocephalic vein. It is performed under analgesia sedation or under general anesthesia using the conventional Selninger technique. And the sterile condition, sterility should be followed as in case of other venous cannulation process. The infant is placed in Trundlenburg position, 30-degree, and shoulder roll is placed below the shoulder of the patient, and the head is turned 45-degree contralaterally to the side of cannulation. It is done with high frequency probe, 8 to 13 Hertz. A smaller footprint is preferred, up to 3 centimeter. The operator, if we are planning to cannulate the left brachiocephalic vein, the operator stands to the left of the patient, and the ultrasound machine is placed such that the screen is visible all the time while performing the procedure. And if we are going to cannulate the right brachiocephalic vein, then the operator will stand just as in case of internal jugular vein cannulation to the head of the patient. The 2D and color Doppler exploration of the jugular vein, subclavian, and brachiocephalic vein is conducted to define the anatomy and the size of the vessel and their permeability. And we visualize the brachiocephalic vein. First of all, we visualize, keep the probe in the mid of the neck at the level of cricoid cartilage, and track the cross-section of internal jugular vein and the carotid. Now the probe is slid down towards the supraclavicular fossa. And this is the image of carotid and IJV when it is placed in the neck. And this is the image that is obtained in the supraclavicular fossa. We can see internal jugular vein, subclavian vein uniting to form brachiocephalic vein. To define a safe trajectory for the needle, first the subclavian artery, subclavian vein, and brachiocephalic vein must be identified by means of tilt maneuver. The pleura and aortic arch should also be identified so that these structures are not injured while cannulating. This is the Doppler, pulse Doppler that can be done to differentiate between the artery and vein. There is a pulsatile flow in case of artery and laminar flow in case of vein. For localizing brachiocephalic vein, this is how the scanning is done. From in the neck, we can see carotid artery, which is pulsatile, and the internal jugular vein, and it is traced down. On coming to the supraclavicular fossa, we can see that the subclavian vein and internal jugular vein unite and brachiocephalic vein is formed. When the view is confirmed that the brachiocephalic vein is there, optimum view is obtained, then the skin is punctured with a 22-gauge introducer needle directly in plane from the lateral side of the supraclavicular fossa as shown in the picture. The needle is directed towards the vessel, avoiding any other structure. This is how needling is done. We can see there is a vessel, and we try to avoid this vessel. And we have reached the brachiocephalic vein. After the blood can be aspirated, a flexible metal guide wire is introduced and the venous cannulation is completed as usual. The position of the guide wire and the dilator may be confirmed by ultrasound during the procedure. Here we can see the dilator. Here we can see the guide wire. Now we place the dilator. While placing the dilator, we should take precaution that only 2 to 3 centimeters of the dilator goes inside. If more of it goes, it may lead to trauma and bleeding. The catheter size is chosen based on the size of the vessel. Usually 3 French and 4 French catheter is used in small kids. And after cannulation and central venous cannula placement, the placement is confirmed using an X-ray or other method like echocardiography can also be used. The critical points about brachiocephalic cannulation is that visual control of the needle should be maintained at all times as it progresses towards the vessel. Any movement, however small, may imply losing the sight of the needle with the potential risk of immediate complication like arterial puncture, pneumothorax, injury to thoracic duct, and injury to the brachial plexus. And therefore, prior experience and training of ultrasound are essential before attempting this approach. Now, which side should be preferred, left or right side brachiocephalic vein? The left brachiocephalic vein offers some advantage over right. The left brachiocephalic vein is larger than the right in preterm babies also, and it has more direct trajectory towards the superior vena cava. Hence, there is higher success rate in the first attempt in left brachiocephalic vein cannulation and lower incidence of misplacement. Ultrasound-guided cannulation of right brachiocephalic vein is technically more difficult due to shorter course, sharp angle, and caudal turn of the vein. Now, caution should be taken while brachiocephalic vein cannulation. In cardiac patient, the left side brachiocephalic vein should be avoided because there is risk of erosion, perforation, and in 5 to 15% of patients, the congenital cardiac disease have a persistent left superior vena cava, which often drains either in coronary sinus or left atrium, which should be avoided. Some people say that because thoracic duct lies in the left side, so it can be injured and left brachiocephalic venous cannulation should be avoided. But practically, we have not encountered this complication after doing so many left brachiocephalic vein cannulation. Several studies have been done. A study was published in Journal of Critical Care in 2016, where a comparison of ultrasound-guided brachiocephalic and internal jugular vein cannulation was done in critically ill children. And they found that ultrasound-guided supraclavicular in-plane brachiocephalic vein cannulation improved first attempt cannulation success rate and reduced puncture attempt and cannulation time compared to ultrasound-guided in-plane IJV in critically ill patients. This is a correspondence that was published in BJA in 2022. This was about a retrospective evaluation of 599 brachiocephalic vein cannulation in neonates and preterm infants, and they confirm feasibility and relative safety of supraclavicular ultrasound-guided in-plane cannulation of brachiocephalic vein in neonates and preterms. This article was published by our department, by our colleagues. This is a review article that was published in Journal of Anesthesiology and Clinical Pharmacology recently. In this, the role of ultrasound-guided brachiocephalic venous cannulation for difficult venous cannulation in pediatric patient was done. And the authors concluded that ultrasound-guided brachiocephalic venous cannulation had a higher first attempt success rate, requires less cannulation time, and has lower complication rate. So our experience in our institute, we have done more than 1,000 cannulation in children in brachiocephalic venous cannulation. And we do it as elective and emergency cases. And these days, this is the first choice for all children because it has improved first attempt success rate and it has tremendously increased the ease of insertion of central venous cannulation. Several researches have also been done by our department related to brachiocephalic venous insertion. So the take-home message is brachiocephalic vein is a safe and practical alternative to cannulation of IJV and femoral vein in children and neonates. It has reported to be feasible even in children weighing less than 1,000 grams. And vascular access of choice in critically ill and premature infant is obviously brachiocephalic vein. Thank you.
Thank you, Sagupta ma'am, for throwing the beautiful insight into the brachiocephalic venous cannulation. And now I request Parul ma'am to kindly invite our next speaker, Dr. Nishant sir.
Thank you, Dr. Vishal. And it's my pleasure and honor to invite my very good friend, Dr. Nishant Sahai, who's not only an academician par excellence, but he is a greater human being. And he has several publications and several awards to his name. He's currently working as additional professor at AIIMS Patna. And his topic for today is laryngospasm in children. So laryngospasm, as we all know, occurs not only at intubation, but it can occur at extubation also. even though it is manageable, but at times, if we do not handle it properly, the child may go into hypoxia and even bradycardia. So, how to handle these cases and such scenarios? I now invite Dr. Nishant Sahat to discuss about it. Thank you.
Thank you so much, ma'am. I hope my slides are visible. I'm audible.
Yes, Dr. Nishant, they're visible.
So again, I must be extremely thankful to the RSACP team, Naveen Malhotra sir, Dr. Vishal Singla sir, and I'm honored to have your presence as well as Dr. Chaube sir's presence for the talk. I see a lot of other very, very senior people, and I feel honored. And I think we have to finish it off before 7:30. So probably, I'll be going a little fast. Dr. Shagufta and Dr. Abhishek have mentioned some problems during management of anesthesia in children, but laryngospasm is very important because in the various trial registries, it has been seen that laryngospasm is the most common cause of respiratory related arrests in children, and respiratory related arrests are approximately 27 to 30% of all pediatric perioperative cardiac arrests. So it is quite important that we know about laryngospasm, and thus in the next 15 minutes, 12 to 15 minutes probably, we'll be knowing what is laryngospasm and the risk factors, prevention, identification, and management. Now, we know what is laryngospasm. Laryngospasm, basically, what we understand is the spasm of the glottis. But we need to understand that total laryngosspasm is not just apposition of the two vocal cords. It is a reflex closure of the false as well as the two vocal cords. And then this is accompanied by the descent of the epiglottis over the laryngeal orifice. So effectively, there is zero chance of any air coming or going out of the glottic opening when there is a complete laryngospasm. There is a term which is called an incomplete laryngospasm also. On the left hand side, like B, you can see if this will be the feature of the glottic opening in complete laryngospasm. But in incomplete laryngospasm, as we can see in the figure C, there is a slight chink which is left at the posterior end. And we shall see in the due course of this lecture how and why it is very important for many reasons. The differentiation between complete laryngospasm and incomplete laryngospasm, although clinically it is quite difficult to differentiate, but we'll see how it becomes important in the slides to come. Now, this is the anatomy of the laryngospasm reflex. Now, laryngospasm is basically a protective reflex, and this protective reflex has an afferent and an efferent. The afferent is by the internal branch of the superior laryngeal nerve, and we must know that the maximum distribution of this nerve, the afferents, is from the glottic surface of the epiglottis. So this is a protective mechanism, and God has made it in such a way that if there is any vomitus or anything that is coming and touching the undersurface of the glottis, epiglottis, then there will be a very severe signals which will be sent to the center of the brain to initiate this protective reflex of larynx, that is called the laryngeal spasm. The efferent limb has the adductors as well as the abductors. And what we need to understand is that the recurrent laryngeal nerve is in association with the nucleus ambiguous. Now, this means that with laryngospasm, there will be changes with the hemodynamics. There will be bradycardia, there will be tachycardia. And if the stimulus is large enough, then there will be adduction of the vocal cords as well as inhibition of the abductors. And the adductors of the vocal cord are all lateral cricoarytenoid, thyroid and cricothyroid muscle, which are supplied by all the muscles are supplied by recurrent laryngeal except cricothyroid, which is supplied by the external branch of the superior laryngeal. So this is the place where probably in incomplete laryngospasm, when the stimulus is not so much, the cricothyroid muscle might be spared and the tension of the vocal cord might be spared. So there'll be a chink in the posterior aspect, which will be very important. There are various stages of laryngospasm. Now, laryngospasm, it actually first begins with an inspiratory stridor. Inspiratory stridor is a failure of the abductor muscles. And in the abductor muscles, there is only one abductor muscle for the larynx, which is known as the posterior cricoarytenoid. And this is the first muscle which is activated in laryngospasm. Now, here we must understand that even in studies, what is the maneuver which causes movement or which activates this muscle? This muscle is actually useful during laryngospasm because it will open the vocal cord. And it has been seen that continuous positive airway pressure, CPAP is one that causes this muscle to get activated. And once this muscle is activated, there will be breakage of the laryngospasm. So in the management of laryngospasm, CPAP is very important. Then there will be an expiratory, there will be an adduction of the true vocal cords. There will be a ball valve obstruction and closure of the soft tissue, which will collapse over the glottis. And this will result later on in complete laryngospasm, where there will be no bag movement, there will be no movement of any air inside or outside of the glottis. So laryngosspasm, as we have seen, it will progress from an initial inspiratory stridor because of the failure of the abduction. Obviously, if there is a problem with the inspiration, there will be retraction of the chest, there will be rocking chest wall movements. And then finally, there will be cessation of all air movements despite inspiratory effort. And especially in a young male, if there is a muscular male with a lot of inspiratory effort against a closed glottis, forces as high as minus 50 centimeters can be seen in the trachea, but there will be no air movement. And this often leads to one very serious complication, which we all know. And this complication is negative pressure pulmonary edema, which is quite common after laryngospasms. So there are various risk factors for laryngospasm, patient-related, surgery-related, but it basically boils down to two things. One is, this is a protective reflex. If the patient is deep enough, the reflex is inhibited and there will be no laryngospasm. The other is the stimulus by the noxious element, and then there is a balance. So this is called the art of extubation at the time of extubation. That is why many people ask you to extubate in the deep, because then there is an inhibition of the reflexes. Even if there is a noxious stimulus, the laryngospasm won't occur. The other is, your protective reflexes are so well developed when you are awake that laryngospasm won't occur. There will be a swallowing reflex. All the noxious stimuli will be removed by swallowing and coughing. So there are many methods by which laryngospasm can be prevented. There are vocal cord irritation by inhalation agents. These are the irritants that can cause vasospasm. But URI is one very important determinant in pediatric patients, which will cause vasospasm or not. And though I'm sure there are very senior people in the audience who have different views, but URI, in our practice, it is important that we manage the patients with URI, and we delay elective surgery for children with current or recent URI. However, if we have to postpone the procedure, it is done on an individual basis based on the risk factors, medical and practical disadvantages of postponement. But there are chances of laryngospasm in these patients. And when we are deciding about URI and surgery, if there is only mild rhinorrhea and mild symptoms and a minor procedure, we normally do not postpone anesthesia. But if there is fever or wet cough, obviously, we do not want to take that risk. But again, these are topics which are beyond the scope of this discussion, and there might be various information and anecdotes in the audience also. So to prevent laryngospasm, we do nasal suctioning secretions while either the patient is deeply anesthetized or awake, and we perform laryngoscopy intubation or insertion of a supraglottic device during deep planes of anesthesia. A supraglottic device and oropharyngeal airways again are controversial, especially when we are we're discussing laryngospasm. But it has been seen that when we use a supraglottic device rather than an endotracheal tube, a meta-analysis of 19 randomized trials found that during emergence, laryngospasm was lesser with use of supraglottic devices. Pharmacological methods have been used. Lidocaine and magnesium sulfate have been used to prevent laryngospasm. But there are two techniques, which is called the no-touch technique, in which we wait for the swallowing reflex to come before we extubate. And then many of us, we do the artificial cuff maneuver where we inflate the bag at the time of extubation so that the next movement is of cuff as soon as the endotracheal tube is removed and the secretions are cuffed out accordingly. So now we know that the diagnosis of laryngospasm is quite difficult. It is actually based on the clinical judgment of the anesthesiologist. There is an inspiratory stridor and paradoxical respiratory movements. And once it causes a complete airway obstruction, there might be other manifestations like hemodynamic bradycardia, negative pressure pulmonary edema. Therefore, management of these cases is very important. So as soon as we identify that there is a possible laryngospasm based on the stridor, inspiratory sounds, paradoxical respiratory movements, we must remove the triggering stimulus. We do a chin lift, jaw thrust maneuver, and start gentle CPAP. Again, CPAP is very important for laryngospasm with 100% oxygen. So, and there is in this algorithm, you can see oropharyngeal airway. Now, many people say that that can cause laryngospasm itself. But during laryngospasm, sometimes we do not know whether it is airway obstruction or not. And oropharyngeal airway also helps in development of the CPAP. So many people, especially, they do not want to take out the oropharyngeal airway, or they do not want to take out the supraglottic devices, because those will provide good CPAP values. Then we have to assess the airway movement. If the airway movement is present, that means it is an incomplete laryngospasm. An incomplete laryngospasm is very, very amenable to two things. One, there is the Larson's maneuver, and then it is also very amenable to CPAP. And there is a third thing that we can do is we need to give gentle thoracic compressions. But in any case, we have to deepen anesthesia, and IV anesthesia with propofol will be needed. Regarding Larson's maneuver, this is CPAP and oxygen is given. Regarding the Larson's maneuver, it is known to break the laryngospasm, and it is the site acts according to Phil Larson himself. There is a notch behind the lobule of the pinna, just anteriorly to the mastoid process and behind the ascending ramus of the mandible. So this is the point where you need to put the pressure. This is the in children, it is just in front of the pinna, and the pressure that you need to apply is a cephalad and a medial pressure. So this is shown to break laryngospasm even during airway maneuvering, when there is jaw thrust, that you can give it by your middle finger. Sometimes people give it with their index finger, and when you're using the middle finger, you can provide jaw thrust also whilst providing the Larson's maneuver using your index finger. So it is better that you provide the Larson's maneuver while jaw thrust also. Why does it work? It is not very clear. Some people believe that the painful stimulus that you provide breaks the vocal cord and causes to relax, breaks the spasm, and allows the vocal cords to relax. And but the exact mechanism of the Larson's maneuver is not known. There is another method that is used, application of gentle chest compressions, and use the extended palm just as we use for the resuscitation. But performing the compression force is less than half of what we use for resuscitation, and the rate is 20 to 25 compressions only. So this is known to shown to reverse laryngospasm also. And laryngospasm, the partial laryngospasm is reversed by CPAP and Larson's maneuver and the gentle chest compression. So that is why it is important. But if there is no back movement and the patient has gone into a complete spasm, we must give muscle relaxation, and succinylcholine is used in the exams. Many times we ask the students how much of succinylcholine, and they say 1 milligram, 0.5 milligram. The answer is just 0.1 milligram, because when we are giving succinylcholine, we want to preserve the spontaneous ventilation. We just want to break the spasm. Rocuronium can also be used, and because there is with laryngospasm, there are other bradycardia, hemodynamic changes. So we must consider to keep atropine and other drugs also based on the hemodynamic changes. Coming to this last slide, if there is an increase in the saturation, we can the laryngospasm is resolved, but then otherwise we can consider orotracheal intubation or cricothyrotomy. And supraglottic devices again can become very useful, because if in either case, if the invasive airway is not failing, then you put in a supraglottic device and ventilate. So I'm sorry if I've taken a little bit more time. I think the next topic on supraglottic devices will be dealt by Dr. Swati.
Yes, sir. Thank you so much, sir. It was very beautiful. listening to you. In fact, the time passed off quickly. And may I request Dr. Parul ma'am to kindly introduce our next speaker, to Dr. Swati Singh ma'am, for her talk.
I would now request my co-chairperson, Dr. Sanjay Chaubey sir, to please introduce the lady.
Extend a warm welcome to Dr. Swati. Now she is going to make a presentation of pediatric SGD placement. So that too in a difficult case, and of course measures to go for troubleshooting in case encountered, which I think would be in non-pediatric anesthesiologists, general anesthesiologists practicing pediatric anesthesia who are not so well versed with it. It would be a great learning sort of a session for them. So over to Dr. Swati, please.
Thank you so much, sir. Very warm good evening to everyone. On the outset, I would like to thank the President and Secretary, Research Society of Anesthesiology, and the RSCCP Patna branch for giving me the opportunity to talk about difficult pediatric supraglottic airway device placement. I'm sorry, 1 second. I hope the slides are visible.
Yes, ma'am, it's visible. You can start.
Okay. Yeah. So what we all put supraglottic airway devices very commonly, but do we really need to know about this? So what the data tells us is that almost 90% of supraglottic airway devices that we put are inserted blindly. And even when they are poorly positioned, we continue to use them if we are able to ventilate the patient. However, imaging studies like MRI, CT scan, X-rays, they have all told us that epiglottis is deflected in more than 80% of the patients posteriorly, and that can lead to issues in pediatric patients. As you can see in this MRI picture, the picture A shows a improperly placed supraglottic airway device. Picture B, it is also supraglottic airway device is stuck in the hypopharynx. In picture C, it has gone beyond the allotted position, and as well as in figure D, where it has gone, which is still in the hypopharynx. So in order to know how to deal with difficulty in supraglottic airway device placement, we need to know what is the ideal position for them. So the alignment of the tip of the supraglottic airway with the tip of the epiglottis and the proximal cuff, that ensures that the supraglottic airway device is properly positioned. Now, when you see in this picture, you can see that this is the tube, this is the mask, which is placed beautifully. This is the level of the epiglottis, and this is where it is placed at the esophagus, the distal cuff. And the drainage tube will be here. When you do a fiber optic bronchoscopic view in an ideal supraglottic airway device, this is how it should be visible. The airway passage is easily visible and ventilation is ideal. Now, in order to be able to understand, we need to know what will be the clinical signs if there is any difficulty or the supraglottic airway device has not been placed correctly. Now, if there is a difficulty during insertion, we will see a resistance to the supraglottic airway device when it is entering the hypopharynx as we place it in the hypopharynx. While we are placing and we are inflating the cuff, there may be dislodgement during the once the cuff is inflated, or once we have inflated the cuff, also the bite block will be malaligned with the incisors. Either it will be too deep or it will be too above. Then after we have inserted, say we have safely inserted a supraglottic airway device, we will see a poor oropharyngeal airway seal. When we insert an NG tube or a Ryle's tube through the drain tube, there will be no patency. It will be difficult and next to impossible to insert the drain tube through the drain tube. And there will be ineffective gas exchange, where there will be, you can see if there is an obstruction, this capnographic pattern will be visible. If there is a leak or if there is rebreathing, the different capnographic patterns will be visible and we will be able to diagnose it. Moreover, if we do the gel displacement test or the Brima-Combe bounce that we do, which is the suprasternal notch tap test, we will see that there will be positive response, and the fiber optic inspection, as we see, a proper device placement will not be seen, and there will be difficulty in able to visualize the airway. Now, this has happened. We have inserted a supraglottic airway. We are able to ventilate, but the ventilation is not good enough. So what are the problems that can occur in the pediatric patients? Any ventilatory failure, insufficient tidal volume, there will be an airway leak, there will be airway obstruction. Especially in pediatric patients, maybe not immediately, but later, there can be nerve injuries. In the immediate postoperative period, there will be airway and tissue trauma, soreness of throat, hoarseness, dysphagia, dysphonia, and even arytenoid dislocations have been reported. And if we try to intubate through the supraglottic airway devices, we will have severe difficulties, and we might not be able to use the channel for endotracheal intubation. Now, in order to understand why and being able to deal with them, we need to know why these problems happen. First of all, as we all know, the pediatric airway is very different from the adult airway. So we have a large tongue compared to the oral space. We have an epiglottis which is floppy, it is U-shaped, it is long, elongated, the larynx is anterior and higher, the trachea is more flexible. These lead to making the pediatric airway more difficult compared to the adult airway. Secondly, pediatric patients generally have a lot of pediatric patients with multiple congenital anomalies can also have associated airway anomalies. So those patients there might be direct contraindication to putting a supraglottic airway devices in those patients. So meticulous selection of patient is also very important when you are thinking of putting a supraglottic airway device. Because if there is any difficulty, an obstruction or a leak, we are unable to give good tidal volume, then there will be rapid desaturation during the apnea phase. Thus, whenever we are using it, especially in neonates and infants, we need to have a high index of suspicion, especially when we are doing blind supraglottic airway device insertions. Now, why? The other why is a malpositioned supraglottic airway device. Now, this airway device, it can be either the device can be malpositioned or the epiglottis can be malpositioned in relationship to the supraglottic airway device. So as you can see in this picture K, in this article by Van Zundert et al., they have very beautifully shown when the distal cuff of the supraglottic airway is either folding backwards or it is folding over. So that will lead to a malpositioned supraglottic airway device. Secondly, if the device has gone beyond and up to the vocal cords, as you can see in this picture M, then there will be difficulty in ventilating. Then the problem can also be with the epiglottis. Now, the supraglottic device has pushed the epiglottis in certain way. There can be a downfolding of the epiglottis in relation to the supraglottic airway device. The epiglottis can be doubled, as in this case, as you can see here, or even without that, the epiglottis can be there in the bowl of the supraglottic airway device. And these all can lead to difficulty in ventilation and other complications. Now we know the problems, the solutions. With each problem will come some clinical finding, and the solution we will talk about each one by one. So the first thing that can happen when we put a supraglottic airway device in pediatric patients, we have a poor seal or there is an audible leak. So that audible leak can be in the form of loud sounds, low tidal volume that we can see either when we are using a Jackson-Rees circuit or we have attached the patient to a ventilatory circuit, to a closed circuit. So what can we do? First, we can try adjusting the cuff. We can lower the cuff pressures, reinflating or deflating and repositioning the head. If the leak is still there, we will need to remove and reinsert a larger size supraglottic airway device. And we also need to know, as we all know, supraglottic airway devices are supposed to be kept in the midline. Any rotation of the tip of the device can lead to the shifting of the tip to one side and breaking the seal, which is needed for good ventilation. The second thing that can happen, an obstruction or no ventilation. What happens is whenever there is the epiglottis, which is the structural anomaly happens, the epiglottis is either folded downwards or the tip has gone too deep. What happens, there is difficulty in ventilation. What are the maneuvers that we can do? We can pull the device back slightly and we can attempt a jaw thrust chin lift maneuver. If, however, even despite that, we are unable to get good ventilation, then we move on to removing and reinserting. Either if we have a video laryngoscope, then under direct vision with a jaw thrust can be done. The third thing that can happen is malrotation or misalignment. As I already said, the supraglottic airway device can be tilted or it can go off center. And as soon as that happens, there will be insufficient ventilation. What we can do is remove, reinsert, and ensure midline alignment. We can use the index finger as a guide along the palate so that we are able to keep the supraglottic airway device in the midline. And we avoid lateral twisting of the airways, which can rotate the cuff and seal will be lost. The fourth thing that can happen, a lot of case reports are there in literature, where you can see that either there is some structural anomaly that happens with the cuff, or the cuff gets removed or torn, or there is a accessory in the cuff that has, there might be a manufacturer defect also. So we need to ensure that we are not overinflating the cuff more than what the manufacturer has told us. And we need to do this to prevent insertional trauma. And despite adequate seal and adequate airway pressures, if the leak persists, then we need to see whether the size is correct, whether we need to go down a size or we need to go up a size. And a torn cuff or any structural issues with the cuff or the shaft of the tube, of the laryngeal tube, or the LMA, or the supraglottic, any other second generation supraglottic airway device, we will need to remove the device and do not use it for pediatric patients. The fifth thing that can happen, which we commonly can encounter in our practices, are a device that is too small or too large. So a supraglottic airway device, which is either oversized or undersized, will either leak or will not set properly. It will push the tongue, it will obstruct the glottis, and we will not be able to achieve effective ventilations. So always check insertion markers on the tube. The proximal rings on the LMA should be just outside the lips when seated. And if the tube protrudes excessively or it doesn't reach the adequate depth, we need to go up a size or down a size. The other thing that can happen when, especially in patients where there might be an obstruction, in pediatric patients especially, we're talking about, there might be abdominal distension. So we need to aspirate using an NG tube and then think of putting a supraglottic airway device. Moreover, if there is any suction or blood in the airway, we need to always suction and take care of it before putting a supraglottic airway device. And the adequate depth of anesthesia is very important, because any patient in a lighter plane, a pediatric patient in a lighter plane, as Nishant sir said, they will land up with laryngospasm. The patient will bite, especially in an iGel, the integrated bite block will be bit by the patient and the child. So the child needs to be adequately relaxed to prevent any occlusion. So now when we talk about all this, we know how to deal with them. I've told you the problems that can occur. I've told you how to address them. So in a larger sense, when we talk about these problems, the authors, Van Zundert, they have done a lot of research on this topic of supraglottic airway devices and how to ensure that they do not fail. So they have devised an algorithm for suboptimally placed supraglottic airway devices based on laryngoscopy. So it can be used to do video guided laryngoscopy, and there are certain standardized maneuvers that I will talk to you about. They can correct the suboptimally placed device, and we can use this flowchart to ensure that we are able to get good ventilation and effective ventilation in these patients. So we will go one by one. So they have divided the supraglottic airway device insertion, the positioning, into 3. Grade 1 is when it is optimally placed, of the supraglottic airway device is optimally placed. And 2 and 3 are when it is not optimally placed, it is suboptimal. So first, what do we see is when we are doing a video laryngoscopy guided supraglottic airway insertion, we see that the epiglottis is in upright position or not. If it is, then we move on and see where the distal cuff is placed. However, if it is not, then it might be epiglottis might be downfolded, or it may be sideways folded. What do we do in those positions? We either do a jaw thrust lifting maneuver or a jaw thrust or use a Magel forceps to correct the anomaly. Now, if that is corrected or if the epiglottis is in upright position, we see the next thing we check for is the distal cuff of the supraglottic airway device in the esophagus. Now, if the distal cuff is folded backwards or it has gone beyond and into the vocal cords, then we need to use either a supraglottic airway device with a reinforced tip, or we need to use railroading bougie techniques. If that is corrected, we need to see the alignment between the proximal cuff and the tip of the epiglottis. If it is correct, the proximal tip and the epiglottis are aligned, then it is absolutely fine. Then we can proceed for surgery, anesthesia and surgery. However, if in cuffed supraglottic airway device, if the airway device is not correctly inflated, either hypo or hyperinflated, or it is too deep or superficial, then we need to adjust because we will hear a leak. We need to adjust, check the intracuff pressures, check the insertion depth and the size of the supraglottic airway device. However, if it is a non-cuffed supraglottic airway device, we might need to go to a cuffed supraglottic airway device. Now, if those things have been taken care of and the epiglottis rests on the outside proximal cuff, then correct position and size are also ensured, then we can proceed. However, if the epiglottis is in the bowl of the supraglottic airway device, as I mentioned and showed you pictures earlier, if there is no downfolding, then there might be, or no doubling, there might be no leak and we might not need to adjust anything. However, if there is any downfolding, then we might need to readjust our supraglottic airway device and then consider proceeding for surgery. And when the cuff is inflated and it is completely deployed, if there is any distortion with the foldings and there is no leak, then we can proceed with surgery. However, if there is still leak is present after correcting all these things, then we need to adjust the intracuff pressures again and think whether we need to go for a different supraglottic airway device if that is still our choice for anesthesia. And if everything is fine, then we go ahead and we proceed with anesthesia and surgery. So this is very beautifully described and can be used in a routine practice so that we are able to give good ventilation to the patients and we are able to avoid the complications of poorly and suboptimally placed supraglottic airway device. Special mention to this article by the same authors, Van Zundert et al., who have talked about the supraglottic airway devices, present state and outlook for 2050. This is article from Anesthesia Analgesia 2024, and they talk about how do we optimize and place and design they talk about other things as well as about design of supraglottic airway devices, what needs to change, what are the good things that the manufacturers have done, what are the redundancies in manufacturing and defects in manufacturing that should be addressed. So I encourage everyone to go back and read this article. It will tell you about the history and the development of supraglottic airway devices. It will talk about what are the problems with blindly inserted supraglottic airway devices and what is the future, which is vision guided supraglottic airway devices. So at the end, I would like to finish my talk by saying that supraglottic airway devices are invaluable rescue tools while we are for anesthesia and in pediatric difficult airway as well. We need to meticulously plan, ensure proper size, lubrication, positioning, anesthesia depth in order to be able to use them successfully. And initial troubleshooting with changes in head positioning, jaw maneuvers, and device repositioning are generally successful. If not, we should definitely limit blind attempts, which we generally commonly see ourselves doing. Sometimes we insert supraglottic airway devices blindly multiple times. So that should definitely not be done. And we should escalate promptly to either intubation or an invasive airway as per the difficult airway algorithms. Video laryngoscopy should be the future, where we insert, detect, correct as we go while we are inserting the supraglottic airway device. So anything that we see can be corrected immediately, and we do not need to reinsert the supraglottic airway device, which will facilitate correct anatomical and positioning, as well as optimize the functionality of the supraglottic airway device. Thank you.
Thank you so much, ma'am. It was really a wonderful presentation. And now may I request our chairpersons, Dr. Sanjay sir and Dr. Parul ma'am, to throw their insights into the entire topic, the session which has been already dealt. If they have any questions to the corresponding speakers, they can just put their questions so that they...
No. Yeah, Dr. Parul, please.
Thank you, Dr. Weber. And I have a question for Dr. Shagufta.
Okay.
Yeah. Hi, Dr. Shagufta. For the benefit of the postgraduates who are watching this webinar, could you please explain what are the precautions you have to take, or what is the care which needs to be taken post insertion of the brachiocephalic cannulation?
For inserting the precaution that I've already mentioned, okay, the cardiac patients who are having congenital cardiac diseases, in those cases, left side insertion of brachiocephalic vein should be avoided. And proper care should be taken about the structures that may be encountered and that may be damaged. So carefully it should be done, and proper size cannula should be used. The cannula size of the cannula for the brachiocephalic, it is recommended that it should not be more than 1/3 of the size of the brachiocephalic vein. So it is better to scan all the veins and find out the caliber of the vein before inserting it. And after insertion, it should be means X-ray should be done, or other way echo should be done to find out whether some complication has occurred. The malposition of the central vein has not occurred, and about the hematoma formation and all these things are not there, and the care should be taken, sterility should be maintained. That if the transparent dressing is there, it should be kept for 7 days. But if the gauze pieces and all are used for covering the vein, then that should be changed on second day, every second day.
So, thank you, Dr. Shagufta. Just with you at the answer session, I would just like to inquire in the sense, can this brachiocephalic CVC axis, can this be standardized for children around, say, in the premature? Because in the premature, of course, as you also mentioned, that it's the safest approach compared to IJV. Now, IJV, at times it may be visible with great difficulty, and subclavian vein that again would have more chances of pneumothorax. So this, on the other hand, provides a straight approach towards the superior vena cava, much straighter approach.
Yes.
And wider. So, I mean, in that early neonatal period or whatsoever, do you think this can be standardized over IJV and subclavian CVC approach?
Yes, sir. I am of the view that it should be standardized because there are technical difficulties, and this can be visualized and maneuvering can be done because there is more space, so the needle can be handled well in this case. Also, the fixation is also more properly fixed. It can be properly fixed because supraclavicular fossa is there. So there are many aspects which there are many studies also that have been done on premature children, and they have found it to be easier and safe. So I also feel that it can be recommended for premature infants.
Thank you, Dr. Shagufta. Thank you.
Yes.
Great inputs on this, and it's been very beneficial. Dr. Parul, if you could please take over.
Yeah, there are two things which I would like to mention, that all of us face the complication in pediatric patient, and laryngospasm is one of the most important and frequently encountered complication. My mantra in this is that it's important to keep calm, give 100% oxygen, and please call for help. There should not be any ego about this that I can manage it, but I think call for help should be done as soon as possible. And Dr. Nishant has explained beautifully about the whole management part. Anything else you would like to add, Dr. Sanjay, to this?
No, absolutely fine. No, I mean, we could have had a more lucid, description of this entity, and it's a wonderful learning experience for the youngsters. In fact, even for the faculty, for that matter, who have been listening to it. Wonderful presentation, Dr. Nishant. I mean, I think any questions further than this could be directly addressed to them. So can we move ahead? Any other question from rest of the two speakers?
So participants can post their questions in the chat box, or they can directly contact the speakers, the faculty who have been here.
So that's perfect. And with permission of the president and the secretary RSACP, should we go ahead with the closing ceremony or pura vote of thanks, please?
Yes, Dr. Sanjay, please.
Yeah. So I think vote of thanks is to be carried out by Dr.
Nishant sir.
I will do,
Dr. Nishant.
I will do the honors. And first of all, I'd like to thank the audience for any webinar. The success is the audience, and I'm extremely thankful for the patience that you all have shown and to attend this conference, to attend this webinar. I would really like to thank our president, Naveen Malhotra sir, who we all know how much he encourages each and every one of us. So that goes beyond any doubt or any words. I don't know whether we should thank him or not, that he does it so often. Thank you, Naveen sir. Honorary Secretary Vishal Singla sir, who has been a constant source of support for all of us. The speakers, a wonderful speaker, Dr. Abhishek Chatterjee from Jamshedpur. Dr. Shagufta Naz is the pediatric anesthesia postdoctoral fellowship coordinator at our hospital. Dr. Swati Singh is a wonderful faculty from IGIMS Patna. I saw a lot of senior people. We heard Maya Tandon, madam. It was an absolute honor to have you, ma'am. Dr. Tej Kaul sir was here. Dr. Paliwal sir, Dr. Sadhna ma'am, Dr. Divyani, Dr. Shamshad ma'am. I'm hazarding taking a few names. Please pardon me if I miss many of the senior members. So to end this, the department, the RSA, the Patna City branch, likes to thank everybody who have joined in for this webinar, and we'd like to sign off. Naveen sir.
I think thank you all, and it was a very nice and academic interaction. And see you soon for the further activities under the banner of Research Society of Physiology. Thank you very much.
Can I just say a word? One more sentence. That Naveen, Sukhminder, and Dr. Bala Venkat, the two conferences in Jaipur, one in GAG 2025, the decision that they have taken, Dr. Mayatanan module to be taken forward, it's commendable. And I think Sukhminder also told Dr. Rakesh Garg to go ahead in this direction and start as an editor. So what Rakesh is as an editor, everybody knows, and he's so inspiring also. So I must thank all of you who have taken the initiative, and today we are pediatric subject. It has been such a big learning back again for me also. Thanks a lot, all of you.
Thank you, madam. Thank you for those kind words. Thank you very much. Good night all. Long live Research Society of Anesthesiology.
Thank you.
See you all on Sunday for the first edition of Research Society of Anesthesiology Youth Conclave. Thank you very much.
Thank you.
Thank you so much, sir.
Thank you.